start talking after Dr. Abdel, who is my teacher. And it's also very difficult for me to speak in both Arabic as well as English, as of today. At the same time, it's really very good to talk about non-Hodgkin lymphoma. And non-Hodgkin lymphoma is really a very fruitful disease for both physicians as well as for patients, since it's a very curable disease and it's one of the few curable diseases we have. Second, most of the non-Hodgkin lymphomas are referred by the internists, and I feel that interchanging the knowledge between oncologists or hematologists and internists is very important. And thirdly, I realized after I trained in oncology that if you understand very well lymphoma, and practically speaking, you understand all the internal medicine things, because once we are dealing with lymphoma patients, we are dealing with all subspecialty of the internal medicine. And I feel that the only problem with this presentation is I don't have a very small entity of lymphoma, so I have to make it, as I promise, I'll make it as much as possible, very simple to make it very understandable. As most of the lymphoma, or most of the cancer, non-Hodgkin lymphoma is not one disease, but considered as a basket of diseases. And usually, this type of neoplasm is derived from different types of lymphocytes, both during its maturation. There are three types of cells that lymphoma arrive from. The first one is the B-cell lymphocyte, both the immature as well as mature form. The second thing is the second cells, the T cells, both mature as well as immature cells. And lastly is the natural killer cells. If we take B-cell lymphoma and we look at this basket, it's really a lot of things. I don't want to talk about every particular disease, but I make it to denote to you how much types we have dealing with lymphoma. The first one is the B-cell lymphoblastic lymphoma. The second is the diffuse large B-cell lymphoma, and this is considered the most common type of lymphoma worldwide. The third one is the mantle cell lymphoma, Burkitt's and Burkitt's-like lymphoma, small lymphoblastic or small lymphocytic lymphoma, CLL, follicular lymphoma, and marginal zone nodal lymphoma, extranodal marginal zone lymphoma, or what's called MALT lymphoma, and finally we have the splenic marginal zone lymphoma. If we go for the T lymphocyte or T-cell lymphoma, they are mainly arise from the immature form, the reduced T lymphoblastic type of lymphoma, the mature T-cell lymphoma, mycosis vigotis, peripheral T-cell lymphoma, and anaplastic large T-cell lymphoma, adult T-cell lymphoma, leukemia. As you see, it's really complicated. And then finally is the natural killer cell lymphoma, and we have one entity called angiocentric, either nasal or non-nasal T natural killer cell lymphoma. Regarding the epidemiology of this lymphoma, usually I select two countries, and because I train in the US, I usually put the census of the US. And in the NCR, in year 2013, they estimate around 66,000 new cases in USA, and 89% or 90% of all lymphomas are considered to be non-Hodgkin lymphomas, while the others is Hodgkin disease. And it represents also about 4% of all cancer diagnosis, and considered the seventh most common cancer in US. Regarding males, they found that it's a little bit more predominant in males more than in females in US, and 90% of them they are adults, and majority of them they are above the age of 60. If we go to Jordan, epidemiology in Jordan, in year 2010, according to the census, we discovered 250 cases, which represented about 8% of all cancer in Jordan, and out of those, 65% is lymphoma, and the other is 65 of them they are non-Hodgkin lymphoma, and the 35% is Hodgkin disease, and this is a little bit much lower in comparative to US, and also it is the third most common cause of cancer in females and the fifth in males. And also in Jordan, we found that female has a little bit more predominant to this type of disease more than in males, and the median age group is much below than in the United States, about 52 years. What's about staging of lymphoma? Staging are divided into 4 stages. Stage 1 is when we are dealing with lymphoma affecting one group of lymph node, just either above or below the diaphragm. Stage 2 disease, when we are dealing with 2 or more than 2 groups of lymph node on the same side of the diaphragm, either above or below. And the stage 3B, when we are dealing with lymph node above as well as below the diaphragm. Finally, stage 4, when we have organ involvement. And usually, the most common organ involvement is the bone marrow, liver, lung, bone, pleura, skin, and brain. And practically speaking, any organ in the body can be affected with lymphoma, but I wonder if cornea is affected or not. I try to figure out if there's any other organ can be not affected by lymphoma. Also, when we are talking about staging, we have to talk about the B symptoms and the B symptoms. Previously, it was 5 B symptoms, but currently, over the last 20 to 25 years, it's only 3 symptoms, and those are unexplained weight loss, about 10% over 6 months, without a reason behind it. Second one is drenching night sweat that really makes his pajama wet, or it can wet the bed, not only affecting the face. And the third thing is unexplained fever above the 38 without any reason. The other 2 was pruritus, and was omitted from the B symptoms. And lastly is the abdominal pain that are common in patients with non-Hodgkin lymphoma, particularly after alcohol ingestion. What about the predisposing factors? There are many predisposing factors for non-Hodgkin lymphoma. The most important one is the personal or family history, and I mean by that patients who are taking chemotherapy or radiotherapy. And it's very important to know that in certain cases of breast cancer, when they are exposed to radiotherapy, they can develop lymphoma. The second one is as I said, both chemotherapy and radiotherapy. The second one is organ transplant. And we notice that patients, especially with allogeneic bone marrow transplantation, as well as autologous bone marrow transplantation, having this would increase incidence of transplant. And among I transplanted almost about 32 or allogeneic bone marrow transplantation. I encountered 1 patient with non-Hodgkin lymphoma. Also, taking medication such as immunosuppressive medication in Iran is a very important agent that can predispose into lymphoma. What's about agricultural insecticide? It was very noticed that patients who are doing agriculture, they are more predisposed to lymphoma. And finally, infection. And when we talk about infection, the most important infection is viruses, including Epstein-Barr virus, HTLV1 virus, and regarding AB virus, the most common cancer that produced by it is Burkitt lymphoma, as well as nasopharyngeal carcinoma. Regarding HTLV1 and 2, there are more chances to develop hairy cell lymphoma leukemia and hairy cell leukemia, as well as T-cell lymphoma leukemia, and also HIV. When we talk about HIV per se can increase incidence of lymphoma, both Hodgkin as well as non-Hodgkin lymphoma, but at the same time, in patients with AIDS patients, they can develop what's called cavital lymphoma, and it was related to the and it's related to herpes simplex 8 virus. Hepatitis B and C also is an etiology for the lymphoma. Bacterial infection. The most common bacterial infection is Borrelia that are causing Lyme disease, as well as H. pylori that are important to develop mild lymphoma or gastric lymphoma. Autoimmune diseases such as lupus, rheumatoid arthritis, and one important disease is the Sjogren's syndrome, and usually one of the most important features of this disease, usually they produce hypergammaglobulinemia, but the minute that this patient develops hypogammaglobulinemia, we have to think of autoimmune disease. other diseases, such as immunodeficiency disorder, and inflammatory bowel disease, such as ulcerative colitis and Crohn's disease. And finally, is obesity. And they found that in at least 2 or 3 studies that if your body mass index is high, you are having a high chance of developing lymphoma. And for people who are practicing oncology, we are seeing a lot of patients who are really obese and they start losing weight thinking that they are doing dieting, but actually they are not, they are having lymphoma. So you have to be careful when patients start losing weight without dieting. What's about classification? It's really hard for me to, within this lecture, to understand the classification of, to present you classification of lymphoma, but usually the types of lymphoma will reflect the development stage of the lymphocyte. And each type of lymphoma can be viewed as a lymphocyte arrested at a certain stage of development and transformed into malignant cells. And 85% of these lymphomas are B-cell in origin, and the rest is about 15% RT as well as natural killer cell. And if you look at this cartoon, the first cell is the lymphoblast, and as those are mature, they are appearing of some markers or surface markers. The most important one is CD19, and Cala positive will arrest on this stage. And we have CD20, and this is a very, very important cell surface marker or thing, and those are present most of the time in the differentiating cells, but at the same time, in some cases where even with the ALL cases, CD20 can be present in those patients, and some treatment medication for such things. And finally, CD38 tube marker is present when you are dealing with immature cells, particularly in the plasma cells, and one step before the plasma cells, and those are responsible for the formation of the immunoglobulins. And the disease, of course, there would be the multiple myeloma. So, what's about evolution of lymphoma? As a medical oncologist, we are our teaching in the first 20 centuries, those classifications only based on the histopathology of the tumor. Because that sometimes, every now and then, we are hearing about what's called reticular cell sarcoma. And in the mid-20th century, particularly in 1960, Rappaport in Chicago, he classified lymphoma according to the method of growth of the lymphocyte as well as cell differentiation. And in the 1980s, where we graduated, working formulation was there. And in the 1990s, particularly in 1994, real classification was there. And the difference between those evolution of lymphoma was dependent on the pathologist, dependent upon the immunopathologist, and dependent upon the clinical feature. In the 1980s and in and early 2001, there are two adopted protocols, two adopted classification, one is REAL classification, and REAL stands for Revised European American Lymphoma Group, and WHO classification. And based on these things, we are talking about the most common one. The most common one is the diffuse large B-cell lymphoma. Second one is the follicular type of lymphoma. Those are representing 25% of the cases. And all the others is very small lymphoblastic lymphoma, mild lymphoma, nodal type, marginal zone lymphoma, lymphoplasmacytic lymphoma, and other type, mantle, and T-cell and natural killer cell. What's about diagnosis? I like to talk about diagnosis because biopsy is a very important issue, and we have a lot of controversy talking about biopsy. First one is to do either a fine needle aspirate for those patients, or to do true cut biopsy or the excisional biopsy. the gold standard way to diagnose lymphoma is to do a surgical biopsy. But if we cannot do surgical biopsy, we can go and do through-cut biopsy. And if it's impossible to do through-cut biopsy, such as in certain type of lymphoma, such as capital lymphoma, we can use fine needle aspirate with a lot of precaution and using a lot of immunostaining. But if the patient are capable to do biopsies, I think this is the best important thing, to ask a surgeon to do a biopsy. And usually we select a lymph node that either big lymph node or we elect to use it above the diaphragm, in the neck area or in the axillary area rather than in one area. What's about staging workup for lymphoma, as most internists do, including myself? We do a CBC, and the most important thing we will find ISR, anemia, leukopenia or leukocytosis, lymphopenia and lymphocytosis, chemistries, including kidney function tests as well as liver function tests. And I want to talk about two important things. I will talk about uric acid and LDH. And if I am confused, when we are dealing with some lymph node, I usually do beta-2 microglobulins as well as LDH. And there is nothing in the world can elevate uric acid as well as LDH except lymphoma, except in one benign condition, which is psoriasis. Otherwise, if you find out that those lymph nodes are associated with high LDH and high uric acid, this is most likely a lymphoma patient. Also, we do staging workup, including PET and CT scan, bone marrow, aspirate and biopsy, and aspirate alone is not enough. Sometimes, unfortunately, we encounter in our practice that some people they are doing for the aspirate, and aspirate is not conclusive in those type of patients. And regarding the bone marrow biopsy, we are divided either to do a single bone marrow biopsy or two bone marrow biopsies, two sites bone marrow biopsy. And there are one study done in United States. They are comparing between two biopsies versus one big biopsies, and they are equal. And also, we do lumbar puncture in certain type of patients, such as AIDS lymphoma or any patient with T-cell disease, high-grade lymphoma with positive marrow, and finally testicular cancer. And those are usually the best CT scan we have. This is the before treatment. We find that we have, and those one of my patients, we have diffuse lymph node involvement in the neck, axilla, intestine, as well as in the abdomen. And after treatment, and those are, this is the CT scan, this is the PET scan, and this is the joint between the PET and CT scan. And this is one of the most important tests which we are doing for staging of lymphoma. And this PET scan is not important for diagnosis, but also important for follow-up for patient. And after proper treatment, the patient ended with the complete resolution of the lost lymph node by the PET CT scan. What's about oncological emergency? As I told, most of the time, the internists will deal with those patients before they transfer those cases to us, and depending upon the site of the involvement, either we are dealing with spinal cord compression, sometimes we are dealing with pericardial tamponading, hypercalcemia, severe vena cava obstruction, as well as inferior vena cava syndrome, hyperleukocytosis, airway obstruction, tumor lysis syndrome. And I will talk a little bit about tumor lysis syndrome. And this type of syndrome are really, you need the help of most of the time of nephrologists. And most of the time it's happened after we initiate the treatment, but sometimes it's happened in high certain organ cells where the tumor or the lysis syndrome will develop before we even start the treatment. And the usual clinical picture or the biochemical problems in tumor lysis syndrome is hyperkalemia, hyperphosphatemia, hyperuricemia, and of course hypocalcemia. Also, it can be associated with an autoimmune hemolytic anemia, and this really is an emergency, and unless we deal with it, we'll have a lot of problems. finally they continue. What's about prognosis? What's about prognosis for non-Hodgkin lymphoma? They adopted in the prognosis 5 points to deal with. The first one is the age, more than 60 years, high LDH, equal performance status of more than 2, stage 3 or 4, and finally number of the extranodal or extramedullary disease. And each one will have points. And if the international diagnostic index score is 0 to 1, then this is good. This will give us about the prognosis for those patients. And the rate of remission is about the rate of, for the 10 years survival will be about 91% for those patients, and the disease-free survival will be 81. If the IBI score is about 2, the rate will be 69 and 81%. Those are representing the 10 years survival, 81%. Then IBI score rate, the rate will reduce to about 65%, and if the IBI score is 45, then this would be about 59%. So the limit of the score will be, the prognosis will be bad. What's about the expanded treatment for non-Hodgkin lymphoma? First one is the traditional modality, and I mean by this chemotherapy as a single agent combination chemotherapy. Radiation therapy. Regarding radiation therapy, most of the time we don't do it unless the patient has either resistance to treatment or if you are dealing with spinal cord compression. And surgery, I think the only indication for surgery is when you are diagnosing patient and we don't do more than that. Regarding the recent modality, we start to add immunotherapy, particularly monoclonal antibodies, and the most important monoclonal antibodies is the toxinab, which is called Nabthera. Radioimmunotherapy, cytokines, as well as interferon. And most of the time, sometimes we combine chemotherapy in addition to immunotherapy as a single agent for combination. And as I told you, the most important drugs that we are using is the toxinab, it's chymeric antibodies. It will go and stuck to the it will stuck to the effector cell that has anti-CD20, and we use it as a target. Tumor cells can fix the complement and mediate reaction. And in clinical trials, what we do, we have the FILA NH 98.5 studies designed. What we are doing, we are taking patients with untreated diffuse large B-cell lymphoma, age above the age 60, and we randomize them between 8 cycles of CHOP versus 8 cycles of R-CHOP. And the outcome for this study was patients who are receiving CHOP alone, which is the standard for most of the lymphoma patients, particularly diffuse large B-cell lymphoma is about 1.5 years, while the median survival for patients who are receiving R-CHOP is about 4.8 years. What's about survival of non-Hodgkin lymphoma? As I told, indolent lymphoma, the life expectancy in years, and untreated patient with low-grade lymphoma, 85 to 90% of them they are presented with stage 4, and they were incurable in the past, but now probably we are dealing with recurrent disease. Okay. What's about take-home? Before I would say, as medical oncologist, also Dr. Abadi will agree or disagree with me, I divided lymphoma into 4 sometimes, and this was called salami classification. One is when you are dealing with a lymphoma patient, we give him chemotherapy and he's cured. And this is a very good lymphoma, whatever it is. The second one is good lymphomas, and I mean by good lymphoma, whatever the histopathology is, we give chemotherapy for patient, he has good response, but unfortunately he relapsed. And once he relapsed, we give him a salvage chemotherapy, and the salvage chemotherapy will end up with also with cure. And also this is a good lymphoma. The third lymphoma is a bad lymphoma. Bad lymphoma means we give chemotherapy, their response, give a second line chemotherapy and even transplant, their response, and they relapse, and then unfortunately we cannot cure it. And this is really bad lymphoma. And the fourth type of bad lymphoma is the lymphoma that whatever we do, we cannot do anything with those patients. As a medical oncologist, I tried, I didn't see any patient with lymphoma because the patient is suffering too much once we are dealing with him. And finally, I will take about take-home messages. One is non-Hodgkin lymphoma is not one disease, and each type will have different treatment and diagnosis. The gold standard way to diagnose lymphoma is biopsy. And finally, chemotherapy is the most effective treatment of non-Hodgkin lymphoma. Thank you very much.
Thank you, Dr. Ahmed, for your nice presentation. We have time for one question. One question.
دكتور تنتبهوا علي هون؟ يلا بين الدراسة دكتور مالك. يلا.
عبد الله العباد عبادي من عباد